Everyone, we'll get started in just a couple of minutes.
Tanya, let's give it one more minute and go ahead and get started. So we won't have
Okay.
that we have a full schedule.
Okay. Good evening, everyone, and thank you for joining us for the second installment of the Prevention Link Health Equity webinar series. And the title of this webinar is The Path Forward, Improving Health Equity with Nurses, Pharmacists, and Registered Dietitians and Nutritionists. I'd like to introduce Twanisha Stokes, who is our Program Chief for Chronic Disease with the Health and Wellness Division and Director of Prevention Link.
Hello, everyone. I'm sorry I'm not on camera. I'm actually just not so long ago leaving Channel 9 News. Prevention Link is being highlighted on Channel 9 News. So it ran at 3:30 and again at 5. So I'll apologize, but I want to thank you all for attending. We have a treat today, so I'm looking forward to hearing from all the speakers. But I want to just I'm excited about these health equity webinars. Again, as Tanya said, this is our second one. We're having one more in June, the end of June. So looking forward to that one as well. And health equity, it plays a big part within Prince George's County and definitely the health department, because our vision at the health department is for all Prince Georgians are their healthiest at every age and at every stage. And health equity is embedded into our vision statement, which is to lead, engage, and empower our community to work collaborative towards disease prevention, health equity, and total well-being. So with that being said, we're doing a lot of things in Prince George's County around health equity. And one of the projects is currently Prevention Link as well. We hosted health equity webinars. We work with HQI. You'll hear from Judy, and throughout the presentation as well. They provide a lot of practice transformation, working with their practices to inform them about health equity, to make sure they're looking for things around health equity. We had several speakers. At our last seminar, we had Judy, who actually provided an overview of the ADA Bill of Rights on health equity. I gave an overview of what we're doing in the county, which I'll briefly speak on again today. We also had Delegate Martinez to talk about the impact of health equity in the state of Maryland. And we had Leah Chambers from HCDI that also discussed the difference between health equity and health disparities. So it was a really good webinar. We have a recording, so we'll be glad to share that recording along with this one afterwards. And so some of the things that the county is doing within Prince George's County, some of our current initiatives include invested in community health workers. So we have several community health workers that help address social determinants of health barriers. So we embedded them in the Prevention Link projects and several projects throughout the county because we know that social determinants of health barriers affect people getting appropriate care and also able to afford the health care. So we want to make sure the patients are connected to have insurance or either connected to a medical provider to make sure they're getting transportation and addressing food insecurities as well. Another project that we currently have within the county is our, it's the federal, it's called, I'm trying to pull it up, apologize, is our Prince George's County Health Assurance Program that reimburses federal qualified health centers for uninsured patient visits to make sure that the patients are still being seen, even if they do not have insurance. We also have, we collaborate with the Prince George's Healthcare Coalition. They have a work group that's focused on health equity. We're partnering with them actually for our next webinar I think it's going to be on June 20th. We'll provide more information about that. And also we receive federal funding from CDC to assist target populations in preventing or managing chronic disease such as diabetes and obesity. And so that just are some of the things that we're doing in the county, and we're looking forward to you guys partner with us. If you're already partners, we're excited, and we're always looking for new partners to help us address health equity throughout Prince George's County and the state of Maryland. And with that being said, I'll turn it over to Judy.
There we go. Unmuted myself. Thank you, Ms. Trinisha. Appreciate it. Good evening, everyone. It is great to see so many familiar colleagues join us today. I wanted to thank our very experienced panel that has joined us to talk about how nurses and pharmacists and registered dietitians and nutritionists can help improve health equity. Our panelists today include, first, Dr. Yvette Conyers, who will be talking to us from the nurse's perspective. She is a champion for health equity, inclusive excellence, and amputation prevention in marginalized populations. Dr. Conyers is a nurse practitioner, and is the Associate Dean of Equity, Diversity, and Inclusion, and the Assistant Professor at the University of Maryland School of Nursing. Dr. Conyers also works with a very diverse student and faculty population at the University of Maryland School of Nursing. Next, we have Dr. Marie Teresa, and hopefully I say this right, Oyalowa, close maybe, who talks to us as a pharmacist from the pharmacist perspective. Dr. Olaloya, oh boy, I've been saying it so many times to myself, I didn't get it right this time. Oyalowa is a professor and director of Drug Information Services, School of Pharmacy, and Health Professions at the University of Maryland Eastern Shore. She earned her pharmacy degree from Mercy University School of Pharmacy in Atlanta, Georgia, and a drug information specialty residency from the Medical College of Pennsylvania, Allegheny campus in Pittsburgh, Pennsylvania. She is also board certified oncology pharmacist. She coordinates and teaches the hematology oncology course, among other responsibilities, and serves as the preceptor to pharmacy students. She is currently serving as president of the faculty council at the School of Pharmacy. Other responsibilities include chair, professional development committee, member of the SAPC, University Faculty Assembly, Faculty Senate Committee, and Faculty Grievance Panel. Her scholarly activities include IRB approval studies, co-PI, WCCC projects, platform and poster presentations and publications. She is a member of several professional organizations and has received several awards, including Pharmacist of the Year, Faculty of the Year, Small Business of the Year, Bowl of Hygia, and Distinguished Fellow of the National Academies of Practice. She enjoys volunteering her time to serve in various professional and community activities. Our next panel is Sherma Jack Brousseau. She is a registered dietitian, nutritional professional with over 40 years experience. She is retired from the Kaiser Permanente, where she provided consulting services and as a health educator for 24 years. Sherma presently working part-time as a nutritionist at the Prince George's County Health Department, Health and Wellness Division, providing nutrition programming for the Dine, Learn, and More program, the Diabetes Prevention Program, and conducts nutrition education workshops for chronic disease prevention and self-management workshops. Sherma has worked on initiatives within the state of Maryland, focusing on reducing and eliminating health disparities, including infant mortality, HIV/AIDS, and oral cancer. She continues to be instrumental in planning community outreach, health fairs, education summits, and working with community-based groups and partners to address food insecurities in Prince George's County. Okay, ladies, very impressive. So here we go. So our first question for today, and it's for all three of our presenters, is how does health inequities affect health and outcomes and the well-being of patients? Dr. Conyers, if you're okay, we'd like to start with you.
That's fine. Thank you very much. I'm pleased to be on this panel with such esteemed colleagues. But, you know, if you look at the definition of health equity, right, it's really about unfair differences in health status or sort of those resources. And last month, I know there was a webinar on that, and the definition is usually provided just to give some context. But in terms of those differences, that can impact how long, you know, someone lives, also like the different health conditions that they face, and the care or resources that can be available to them. And it's unfortunate, but health disparities can impact someone from an individual level and also systemic levels. And so I just want to give a couple of examples. Physically, right, some of the health outcomes that can happen because of health inequities include things like high blood pressure or increased blood pressure, as well as maybe some headaches, difficulty sleeping, and a lot of that's related to chronic stress, right? That may not be an individual decision, right? That may be something that is being caused on a systemic level. Another example, psychologically, I talked about physical, but some examples of other health outcomes that health disparities can impact include things like anxiety, depression, also someone's self-esteem, right? And looking at trauma from that too. And then if someone is employed, it can also go on, health inequities can go on to then further impact someone's job security or job satisfaction, as well as burnout. And so all of these various, you know, health inequities from, again, an individual level to a systemic level can impact folks on various levels, physically, psychologically, and then also with employment and loss of finances can further cause some psychological impact as well.
There we go. Take myself back off. Thank you so much, Dr. Conyers. Sherma, the same question for you. How does health inequities affect health and outcomes and well-being of the patients that you've seen?
Well, and thank you, Dr. Conyers, because it seems that we still have the same problem, and the answer is similar. They all are the same. Health inequity, it really affects individual and the whole community. When there is a severe either loss of job, and I've seen it constantly, people may be able to eat healthy, but once that job is lost and their family income has decreased, that plays a big role on that individual, on that family. What do? They go to the most inexpensive food, which is sauce, which is not good for their health, creating a problem of, you know, either obesity, food addiction, and also problem with diabetes, heart disease, and everything else. So this is why I go back to our vision statement from the health department, that everyone should have the opportunity to have good health, and possible regardless of whatever race or color or even ethnicity or even culturally, because we have a lot of people from different culture right in this small seminar. We have diverse people from different countries, and they come. I would say we come because we come with our own food choices, and when that is not available to us, what do we do? So that is one of the the issues that I'm facing.
Thank you, Sherma. Dr. oh boy, I had it right. Oyaloa, what is your perspective on how these health inequities affect health and outcomes and the well-being of patients that you see? Oh, and you're on mute. Here we go.
Thank you, Judy, for the introduction. And I'm going to be responding from a different angle, acknowledging what my two predecessors have just mentioned, but bringing some examples that have actually been reported in literature as how the inequities affect health outcomes and well-being of patients. And when responding to that question, my first word was negatively. Okay, it does. I've never seen any health inequity affecting anybody positively. So my word was negatively. And I give some examples of, in JAMA Cardiology in 2022, where the outcomes of patients with atrial fibrillation were analyzed, and the patients were hospitalized, and it was almost 70,000 patients. And when they were being discharged and sent home, the minority patients or Black patients did not receive the anticoagulants that they should have been receiving, which is standard of treatment, evidence-based guidelines. And what happened? They had the worst outcomes, adverse outcomes, including mortality and stroke. Okay, so again, that's just an example. And then, we talk about, I'd mentioned to you guys about my specialty being in oncology. We know about, females, especially our population, African American, breast cancer example. While there's higher incidence of diagnosis in a white population, mortality rate is higher in the Black population, and the reasons behind that is nothing else but the health inequity faced by the minority. Finally, another example I want to provide that is also documented in the literature is the high incidence of mortality from cancer in both men and women of Asian descent. And now, why is that happening? They also have lower rates of screening. And if you don't screen to identify those patients, obviously, when they go in for diagnosis, they're going to be diagnosed at late stages of the cancers. So I just wanted to provide a few of examples, but overall, health inequities affect the patients negatively and produce, we want optimum or maximal outcomes, but they produce, the worst outcomes. Let me put it that way to summarize.
Oops. Okay, thank you. Thank you so much. And to stick with you here, I was wondering if you could tell us, how does race and ethnicity impact access to medications, prescriptions?
Oh, okay. So they also, I will be giving a lot of quotation from literature. We talk about the social economic backgrounds, the challenges that most African Americans face. And you can find some documentation in literature that says when the African Americans were living with the white population in the same type of environment, earning the same higher rates, there was no differences in disparities. But when you have the socio-economic background into play, prescription affordability is one of the things also. Lack of access to the pharmacy and primary care physicians, just by the nature that these individuals the low socioeconomic background individuals cannot get to those providers. That is how it's going to affect, the access to those prescriptions. And the overall outcome of that, Judy, is that results in non-adherence, So sometimes the prescribers can write the prescriptions and send it to the pharmacy, but if they don't have access, if they don't have transportation to get to that pharmacy, they would never take that prescription. And that, again, will result in negative outcomes.
Sure.
So,
do you think that pharmaceutical companies can do anything to help impact health equity
I do
or inequity?
health inequity. I do believe that, and there are several ways. I know the questions have been asked randomly because I know I have witnessed what the patients go through. Pharmaceutical companies have what they call patient assistance programs, but nobody knows in depth, but those of us working in the institutions, that those programs, they don't cover the complete course of treatment for those patients. Why would you start treating a patient? And again, going back to an area like cancer, there's some cancers where if you don't treat continuously, they recur. So I have talked to some other oncology pharmacists and even other disease states, and the fact is they would provide the medication just for a short period of time. It could be a week's worth when the course of therapy is about a month. So what good is it doing to the patient when you are not providing them? So I really think the pharmaceutical companies can do a whole lot by actually providing the medication for the entire period of treatment for those patients. And that would really relieve a lot of, burden on these patients, and decrease health inequities.
Great, thank you. Thank you very much. Sherma, I have a couple questions for you, my dear. Can you share with us what food equity is? I see that comment in the literature and so forth. Can you maybe give us a brief description about what that is? Oh, you're on mute. I want to hear you.
So sorry about that. I'm just listening. I was so intense with, our colleagues in information, because I had some experience myself. So that's why I was so involved with it. Well, with food equity, the same things similar to health equity. Everyone should be equal to have the same food, should be able to consume healthy foods, and should be affordable. And as what we are seeing is that there are food deserts, and I don't know if you'll go into that. And these are areas that lacks access to, to healthy foods. And there's no fresh fruits, there's no vegetables, there's no, major grocery stores there. And we call it the corner store. I was involved in a project about a couple of years ago, 2020, called the Healthy Corner Store. And what we did is that we went into the zip code areas that were food deserts areas, and we were trying to promote the Healthy Corner Store to help them to bring in some fresh fruits and vegetables. And when I did a couple of the interviews to the stores, and I said, well, could we get you to purchase some healthier food choices? And the guy said, and most of them said, well, this population, they won't purchase it. They won't buy it. If we have fresh bananas here, it will go to spoil. Nobody's going to buy it. Nobody's going to buy fresh oranges. And what I realized was, one, it's a lack of education. People in that area, they have no idea what fresh fruits and vegetables mean. It's easy access to go into that area and buy, and again, we are talking about low income. It's easy to buy 6 packs of ramen noodles to feed a family of 4, because yes, it's easy, at least they would fulfill. But guess what? There's no protein. There's high in sodium. They're lacking their vitamins and minerals. And that is what we are seeing in these areas. We need to make some changes. And unfortunately, due to COVID, that program had stopped. There was no followed up with it. But this is something that, I think we need to go back and revisit to make sure that these corner stores are providing. And just a quick example I want to tell you, and I hate to take up too much time. But one of the corner stores I visited was a mom and pop. I met the parents of the store, and the father had diabetes. So I talked to him about a health department and what we provide. I went back about 6 months later when the COVID started, and the store was empty, and there were young people in there. And I walked in and I said, hello. And they said, can I help you? And I said the wrong thing. I said, I'm from the health department. And they automatically thought I was there to inspect. And I'm like, oh no, Shuma, this is the wrong way. And then I said, no. I spoke to your parents and I was promised your dad that I would bring back some information. And he said, oh, they couldn't afford to keep it up. Now, this store turned from a corner store to a tobacco store. And and the young man said they weren't making money with the corner store. So he took it over, and this is what was happening. And that is what's happening with our food deserts.
Wow. Very impactful. Is there a similarity or difference when you hear food equity, food insecurity, and nutrition equity? Are they all really the same thing? Is there something different about each of them?
Well, they are similar and they are different. The nutrition equity is the same in that they are lacking nutrients. Nutrition equity could happen in any form, in any stage, because you can be in a wealthy area too. And what is happening is that education. People are not aware of what to purchase, what foods, what nutrients. So they are having the food, but they lack to purchase the right nutrients. They're not getting the food, the healthier choices. And we are seeing, and it's not that they could afford it, but their knowledge is not there. So that I've seen also. So that nutrition gap, that's a big gap there. And the other is that a lot of time people use more processed foods because of convenience. It is easier to go and purchase frozen dinners instead of buying, even a rotisserie chicken and purchase. So this is the nutrition gap. The processed foods is, even though nutrition equity is not only, it could serve also as inequity too, because you have the food, you have the money, the finance to purchase it, but you lack the education.
Okay.
So we're seeing some differences there.
Okay.
I don't know if that makes sense to you.
Absolutely. Absolutely. So I'm going to move on to Dr. Conyers now. I do have some questions for you. Are there some tangible actions you think that nurses could take to help promote health equity in their institutions?
Yeah, definitely. I think it's important that nursing is rooted in social justice. If you look back over the years that we have been doing nursing, it is rooted in social justice. It's also part of our ANA, or American Nurses Association, Code of Ethics. And in recent reports, there's a report called The Future of Nursing 2020 to 2030, charting a path to health equity. And that report highlights healthcare disparities, and I'll put that link in the chat. But that report highlights disparities and also talks about our role in promoting equity, not from just the inpatient level, acute care in the hospital, but getting back into the community, getting back in the boots in the ground, looking at population health, looking at community health. At the same time, trying to look at keeping costs low, looking at technology and how we can make things sort of patient and family-centered care. I don't think we can really talk about health equity without really looking at what COVID-19 did for us and the impact on nurses. We all seen it in the media, and we, continue to unfortunately see the consequences of when we did not address health equity before that. I also think it's important that when we talk about health equity specific to nursing, we have to look at the history of nursing and our profession and racism. And I'm not talking about individual racism, but I'm talking about racism, again, on a societal level, on a systemic level, in what's been embedded in our institutions. When we look at our policies, when we look at certain procedures, when we look at certain things that we do, we have to begin to ask ourselves, why are we doing it this way? Who is it allowing not to have the power anymore? Who is it continuing to further marginalize? Who is it continuing to further oppress? I think, too, a lot of times we focus on health equity. We look at racial healthcare disparities, racial equity, but we also know there's inequities among other groups, such as This is Pride Month, right? Happy Pride Month. But we
Mhm.
also look at inequities among those who identify as trans. And if you have intersectionality, maybe being Black and trans, or trans female, maybe having English as a second language and the linguistic barriers that may come, and all our other identities, right, that may cause us to identify who we identify as, those can further cause health inequities, unfortunately, due to how people are treated, due to racism, again, individual level, all the way up to systemic level. It's important in the health equity work, regardless, that we think about allyship. And specifically in nursing, we've been talking about allyship over a few years, but recently over more recent report that talks about racism in nursing. And I'll say allyship is defined by this, and I just want to share this. It's an ethical duty through intentional interventions, advocacy, and support to eliminate harmful acts, words, and deeds, and creating space to amplify voices that are not traditionally heard, recognized, and welcome. And if each of us in our own respective institutions as nurses can begin to take on that mindset of what it is to be an ally and what it is to practice allyship, it's not just one and done, it's a process, it's a journey, then I think the way that we show up for others can begin to change, and collectively we can address health equity better.
Wow. You know, it's sort of, to me, with what you're saying, it really gets back to what should and how should we be treating everybody, right? You guys,
Yeah, right.
it's not,
Yeah.
nobody's different. You know, I look at us as we are all created beings, period. And every person deserves that focus. So thank you very much. Dr. Conyers, I was wondering, do you think that health equity should be or is part of ongoing education and training for nurses, not just those new nurses coming up, but even going forward? I think that there may be a missing piece in some of that. What do you think?
Yeah, I do. I think it goes back to my comment around the nursing profession. If you have old school nurses, right, and we do, but that have been doing things for a very long time, sort of the status quo, this is the way I always done it. That's when things get a little tough to fight, and things in addressing health equity also get harder. The American Nurse Association didn't allow Black nurses to come into their organization until like the 1960s or 70s, and I may be even shorter than that. That's not that long ago, right? And so already, when you look at how do we ensure that we're preparing nurses to address health equity, you're right. We have to start with our students, in which we are, and at the University of Maryland, it is embedded in our curriculum. But we also have to look at the preceptors and those who have been floor nurses for a long time. And again, looking at what are those policies? What does that promotion look like within institutions? Who's getting promoted? Who's at that leadership table? Who's at the table and who's not? And encouraging folks to pull up their chair, right? And create a seat at that table if they're not. And empowering folks, not empowering folks, but helping folks find their power within to also use their voice and, again, be advocates for those who have historically been marginalized.
Wow, absolutely. So I wanted to, my next question, and thank you, that was very beneficial. Do you see a role where nurses can play to help identify and addressing the patient's needs as it relates to social needs? Do you see that at all, as far as how do they do that assessment or collect that information?
Yeah, Judy, I think it goes back to that key word you mentioned, humanity. Humanizing the person in front of you. That person in room 2B is not the diabetic Mr. Jones, right? That person in room 34A is not the COPD patient or chronic obstructive pulmonary disease. They have a name, they have a story. We all have stories, and it's about listening to one story. Unfortunately, in hospital settings, it's hard to spend time with your patients, which is, I got out of hospital nursing early, and when I fell in love with nursing, I fell in love with community health or public health nursing, visiting folks in their homes, because I was able to spend time with them, and I was able to see that all the stuff that I was doing in the hospital only accounted for about 20% of their health. 80% of healthcare of all of us, right? And the impact of healthcare and our outcomes comes from non-healthcare specific things, the food that we mentioned, right?
Yep.
Access to providers who are culturally aware and culturally responsive. The safety in our environments, are we able to walk? So when you say, Judy, I want you to walk, 2 miles every day in your neighborhood. Do you know where I live, Doc? Do you know where I live? And I'm not able to do that. And so, yes, I do see a nurse playing a role, and it's about understanding that person in front of you and their story and not treating the disease, but listening, being respectful, and being intentional. And I think if we can begin to realize this and also make sure we are trying to build community and build relationships, that's a start.
Excellent, excellent. I was wondering, Dr. Oyelowo, and what do you think about this last question and the steps that pharmacists can take to bring to the plate the impact of health equity to their patients?
Okay, there are several things that we are already doing. And I'll give some examples. Actually, I owned an independent pharmacy for 20 years, and I just, sold it, when the responsibilities were getting too much. And I remember instances where I actually had to go to the patient's home to administer the COVID vaccine. They were unable to come to the pharmacy. Pharmacy has done a lot, especially during the COVID-19 period. They were able to be providing the vaccines, and it didn't matter whether the person, whether the socioeconomic background, the race, and we administer to everybody. So pharmacy has been doing a lot. And one of the things that we really work on, which I know Yvette mentioned too about, that personalized care, is advocating. We advocate a lot for our patients, and the way we do it, we go to the heal days, as we call them, heal days, and we talk to our delegates and senators about changes that need to be made about practice. The community pharmacists, you'll see statistics always saying most patients live within 5 miles of a pharmacy. Okay. Well, so they are most accessible, the community pharmacies, and they've been studies now looking into how they can actually improve health equity, in the community. And there are some means of, they don't just have to do it in the pharmacy. They can go out there, engage with the community. There are opportunities like health fairs. I just recently conducted a health fair at my church, last month, brings in people. Actually, somebody came from the county, PG County Health Department with like a food recommendations. I thought that was very impressive. And there were a lot of people stopping by the table because it had these things that looked like real food, the fruit and vegetables and everything. So those are some of the ways that, community pharmacists can actually reach the patients. Now, I know most of you must have heard about some of the chain community pharmacies, how pharmacies are overworked. I mean, this is doable as long as pharmacies also are given opportunity to that additional time to engage with the patients in the community. The question you asked, Yvette, was the same thing that pharmacists can do. They can collect that history. They can tell whether somebody is able to come and pick up their medication. Another service that I offered without charging was delivery services to patients 65 and older, because I knew they couldn't come to pick up their medications. Those are things that we can do, but not everybody wants to provide that type of free service. I cannot speak for them. There are good pharmacists out there that want to do it, but they also have to be compensated. And that is what you hear us talk about provider services. We've been taking this to the to our congressmen, to our lawmakers, about providing some kind of provide compensation for providing the services. That way they can bring in more employees, to guide the pharmacists while they are providing that one-on-one care with those patients, especially patients that are in that category, the marginalized patients. Some of the patients need additional help with education. One of the great things that they did with the pharmacy systems in the pharmacy was to add different languages. I know the system that I used to have to fill prescriptions, it actually had labels in Spanish. I could just activate the Spanish aspect of it and it will print out the label in the Spanish. So, bottom line, community pharmacists are doing everything possible to resolve this issue of, we are very much aware of the health inequity and will do everything possible to decrease that incidence of, I know it's going to take a long time, but we are working on it. And one of the things too that I want to just add on is collaboration. No healthcare professional is an island. We need to work together. I wish I'd met well, Sherma before. I would have even had. I always wanted to have a nutritionist in the pharmacy. Okay, and heads up to the nutritionist. One of the things I didn't tell you at the beginning, I am talking to you guys here now as a survivor. Okay, I didn't want to, and take it whatever. Yes, I'm a survivor of a stage 4 disease. And the reason why I remember now and I'm talking about Sherma is that when I went to the institution, it was over a year before I could even talk to a pharmacist. All right. I'm a pharmacist. I'm a board certified oncology pharmacist. I advocate for myself. Now I start thinking, what about that lay person? What about that marginalized person who doesn't, no pharmacist would have been talking to her or him, and what happens? Negative health outcomes. So the only person that I got to see that came to me first, and that helped a lot, was the nutritionist dietitian that showed up. And we talked and brought me some references. And actually, I remember the Cancer Fighting Kitchen is one of the references she brought. And I have recommended, I'm sure those people, those authors have been making a lot of money from that book because I found it useful and I've recommended to a lot of, when I go to talk to patients, and I always recommend that book to them. Okay, so that's one of the things I wanted to just bring up. The nutritionists, I always think that they should incorporate nutrition in all disease states, okay, especially like the cancer. But I didn't want to forget about that collaboration. It's very important that we healthcare professionals collaborate and have one voice and put that patient as the center of our care. And it doesn't matter what that person's social, economic, racial or background is. We need to provide, equity in care.
Thank you. Thank you very much. So Ms. Sherma, I have a very similar question to that I had with Dr. Conyers for you, is that what role do you see, and clearly we got some preparing me for this question with you. So thank you very much. What role do you see the registered dietitians, nutritionists playing in identifying and addressing their patients' health-related social needs?
Oh, that's great. I just want to say thank you to Maria Teresa Oya. And I'm not going to pronounce your last name.
Oyalo.
But I was the person at your church with the food display.
Oh, you? I thought I saw that name.
I was the person there
that face looks familiar.
You came by, then I realized you came by my table and you was like, is that real food? And
yes.
I was showing you.
Okay.
Yeah, that was me. That was me.
Yes, I know you look familiar.
Yes.
See how we're working together, that's what I mean.
Yeah, and that's part of the answer to the whole question. Poor nutrition is the leading cause of illness. We in this country state that this is the richest country in the world, but yet we have malnutrition. Why? Why do we have malnutrition? And I see at the school, we have a higher incidence, especially the school, with obesity, type 2 diabetes, hypertension, and heart disease. And all because of lack of education. My goal is to do exactly what I do, go out into the community. We have to collaborate. We have to educate. That is the key. People are not, they may be, I don't care what degree you have. As a doctor, the pharmacist said, if you don't know nutrition or you don't know, you're not into that realm, you are lost. We have to know when to eat, what to eat, how much to eat, and we have to educate it. We have to, for my role, I go around and I talk to people, even in the supermarket. If I see somebody's picking up a package and the label is wrong, I would go up and say, what are you looking for? Does that have whole grain in it? Let's look for something that have 100% whole grain rather than buying this. Even if I have offered to pay for some, well, that's too expensive. I say, I'll pay for it for you. And that's what we need. We need to go to the community centers, go to the churches, go to the schools, communicate with each other in all different areas that we could educate. It is not an easy task. As I said, we started with the Healthy Corner Store, and for some reason, it was not sustainable. We have to look for products and for things that are sustainable. How would we continue this? We cannot start a program and then in the middle of it, where it just drops. We have to look for some more sustainable outcome in this to prevent these diseases of malnutrition and obesity that we are seeing right now. The lack of consistent care. And people start off, like I mentioned before, you may have had a good job, but what happened if, because of COVID, you couldn't work? What happened? That consistency of providing for your family has gone. So we have to be able to have an outlet. It's, how could you get the food stamp? How would you get somebody to help you pay? And sometimes pride is also a big issue. There is a lot of pride because if you live in a well-to-do society in an area and you cannot afford to pay your mortgage, or you'll pay your mortgage but not feed your family. And that's what happened, because you want to keep that stigma up. You want to make sure, well, we live in here, I can afford to have this kind of car, but yet your family is suffering with malnutrition and resulting in a whole lot of other issues. So my goal and my recommendation would be to collaborate, educate, share the knowledge. And if we all on this panel today, we can start working on how could we communicate in those lower income areas, those food desert areas, the food swamp areas, and work together. You can help me and I can help you. I'm not a pharmacist, so I may not understand the medication, but I could understand what the medication, the side effect of the medication, and how we could implement it. I'm not a nurse and I may not know how to change the dressing, but I know if that nutrition isn't good, that wound would not heal. So it's a whole team approach that we need to work with. So I know I talk a lot, so thank you.
No, you talk wonderful. Yeah, look, we're
sorry.
clapping, good things.
I get very emotional with this.
It's okay. Emotion's good. Please share your emotion. Dr. Conyers wanted to let everybody know that she shared the link in chat. We're about 12 minutes to go. And so what I thought I'd do, depending upon the questions, is see if there's any questions anybody has. I do have a couple more questions, but I wanted to give our audience a chance if they had any questions for a few minutes. I think Amarachi was going to go ahead and read them if there are any questions in the chat. And if not, I have more questions. And then just some closing thoughts after listening to these amazing ladies. But any questions that anybody has and want to put in chat at all? I think they've been very thorough in what they've asked, but do you have any questions, our audience, at all? Okay, you gotta snooze, you lose, because I have more. All right. Okay. And they know this too, the wonderful panelists here, they know that I had more questions. So I wanted to ask the same question to all three of you. And we'll start, Dr. Conyers, with you, if you could answer this. So tell me, about some specific share some specific health disparities that you've seen specifically in your career as a nurse practitioner, and so forth. What do you think? Are there any specific health disparities that you've seen?
Yeah, thanks, Judy. Every day, right? Every day I'm seeing health disparities, but there was a time I couldn't name it. I didn't know they were called, right, health disparities. I knew that certain groups were not receiving the same interventions and their outcomes were not the same. I think I chalked it up, a lot of it to individual behaviors, but then as I got a little deeper, realized it's not always about individual's choice. All right, it's also about just what they can do with what they have been given. It's not always the choice. And again, until I started working in home care, that's when I realized all those other important factors also contribute to health inequities or further perpetuate the health disparities. In GYN oncology, looking at cancer, right? Specifically cervical cancer is what I was on the floor for, looking at who was coming in with those later stages. That a lot of that can go back to screening and who's getting screened and who's not, and when someone is accessing care to get screened, or when it's just brushed off as that's nothing, right? We look at that also related to Black maternal health. When complaints and true concerns are just brushed off as that's nothing, right? And it truly is something. Those are the health inequities that we see that unfortunately lead to health outcomes, including death. Again, I've also seen it in things like sickle cell disease, chronic pain management, right? When you get titles such as frequent flyer coming into the emergency room, right? They're just drug seeking, they're just whatever. The person's pain is what the person's pain, what they say it is. And we have to treat that accordingly. And when people get dismissed for how they feel, you can see how that begins to impact them mentally as well. Again, that increased depression, even, unfortunately, maybe leading to suicide. And then again, I mentioned with the COVID-19 pandemic, the who has and the who has not, right? Who was able to get access to testing to start with, and then who was able to get access to the vaccine, right? And I recall even a situation where hospitals had their VIP list, and those were the folks who were getting access to the vaccine before those who had all the chronic diseases that we were thinking were the ones who really needed it first because they were immunosuppressed. They had diabetes, right? They were obese. And obviously in the foot care space and in the amputation space, if I was to do a heat map, and if I was to overlay a heat map of where folks live, depending on their income, depending on their insurance status, depending on their race and ethnicity, you will see a higher level of amputations. So zip code matters, right? And that's also something that folks don't think about. We can live 5 miles apart, 10 miles apart, and my life expectancy, right, because of policy, because of politics, because of isms, can be 10 years less than yours, Judy. Just 5 miles
fair.
apart. Right?
Not fair.
All right.
From my
I'm done.
perspective.
Thank you.
Not fair. Thank you,
Yeah.
ma'am.
You're welcome.
Dr. Oyola. Whoa. Would you be able to share any of your what you see as far as disparities that you've observed in your career?
Yes, just like Dr. Okonya said, I've observed many, but I have some recent examples, and I want to take off time because I know Sherman will have time too. So my most current one was I was invited to go and talk to a group of breast cancer survivors, which, I mean, it went very well. I always go and introduce myself. I'm a survivor, and everybody lightens up. So, but what shocked me was this was in an area where breast cancer was common in both races. And I walked in there and they were all white females. I mean, don't judge me wrong, but I enjoyed, we had a good time there, but I was a little disappointed that I would have loved to even see one of those popular marginalized individuals that actually have a higher mortality rate from the cancer. So, but there was none. And then following an example that Dr. Conyers just mentioned, one of the institutions where I was precepting, we went, there was a patient, a stage 4 disease patient that we had been talking to. So one morning when I went in, I got a complaint that the patient had not been coming in for their treatment, African-American patient. But the patient also had a history of substance abuse. I was disappointed that day with the staff or the person that gave me the information, because when I went to talk to this patient, I mean, honestly, and she was very coherent. I took my student there. We went and asked the patient because I educated her on the importance of not skipping treatments, especially when you're dealing with something like cancer. And then she explained to me, she told me she had no transportation. The person that used to bring her to the station when she could not get the MAC transportation, as they call it, was her daughter. Her daughter is a single mom, minimum wage job. So she had to sacrifice not coming for treatment so that her daughter can earn something and take care of that child. So, but when I was given the information, the first thing that they pushed ahead was, oh, it could have been from her substance abuse that kept her from coming. But talking to that patient, it didn't. So that patient was already stigmatized because she had that history, but she had an honest reason for not coming. And I wish, we just talked about transportation being a barrier to them, obtaining that health equity. And then I have a personal experience. I was referred also to a really well-known institution for second opinion, and I went that day. I had symptoms, and the fellow came in, had gone over my chart, even though he was presenting information that was not quite correct. I had to be correcting him. But making a long story short, both individuals, the fellow and the attending, they were white. But when the disappointment was when the attending came in, she just talked and talked and talked. I was never even touched. I was never even examined, even though I said I had some abdominal pain, upper quadrant and everything. And I left that place very disappointed. How do you think I feel? And I have to feel as a minority patient because they classify everybody. They don't even know so I have to feel like I was treated differently. So it didn't make me, something. I mean, it didn't make me happy at all. And so I have another similar example, but I'll let Sherman have an opportunity because I
Please.
see the time is, but I have so many examples, recent
Oh, I'm
examples.
sure. Unfortunately, I'm sure. Sherma, please go ahead. And then I have a couple words.
I want to
A couple words to close us out, and then we'll let
I was
Tanisha.
enjoying listening to it,
I know,
I'll be
exactly.
mine is more community. I used to do these tours at giant called supermarket tours. So I would do it through all the giants. And I did a tour earlier in the daytime at a supermarket in at Kettering. And I left there and I went to one in Suitland. At the supermarket in Kettering, I would make the tour and I would talk to the participants about what foods that they had on display. And at Kettering, they had food display with cereal. They had the high fiber ones, the no sugar ones were on display. I went to Suitland and all the cereal that was in display was the sugar coated one. And I'm saying, what's the difference here? And I think Dr. Connors was talking about zip code areas. But they were just a few miles apart. But here it is in the Suitland area, they had all the sugar-coated cereal, which is not good for our community. And so I spoke to the manager about it, and he said the same thing. He said, well, this is what this is what they like. It's not what they like. We are supposed to be promoting healthy eating and not what they like and not what brings more profit to your store. And that is what I was saying. And I did the same thing at a McDonald's. And one morning I was late and I said, I'm going to stop at McDonald's because they had oatmeal and they had apples. Excellent source of breakfast. Promoted all over. I went to one in Temple Hills, I think it was. I stopped at the McDonald's and I said, oh, I'm looking for breakfast. Could I get the oatmeal with the apples? He said, we don't sell that. I said, what do you mean you don't sell? Nobody's here buys that. And I spoke to the manager. He said, if I said, but it's advertised all over. He said, well, if I buy it, I bought it a couple of times. I just had to get rid of it. And that is, again, lack of education and where we are. So that's mine. I have a lot more, but I know we have run out of time, but I enjoyed talking to everybody.
Thank you, Sherma. I think we're going to probably be able to talk to you guys again. I hope. I have a feeling. I wanted to sort of close out our overall time here together, and I wanted to, there's some words that have been coming up to me, and I sort of want to share these words with everybody and have us think about it. And one's going to go up to the other and the other and the other. I mean, I don't think that any one is more important, but here's what the words that came across to me. 1, access. 2, marginalized. 3, collaboration. 4, humanity. 5, education. And 6, sharing the knowledge. More than one word there. But again, these are things, the themes that kept coming up as I'm listening to all of you talk. And I so appreciate your time today with us and sharing this with us. So beneficial. I look forward to continuing to work with each and every one of you. I think that our audience will be very excited to get to hear and know more about what you guys are doing. Bless each and every one of you. I'm going to I think it's going to be Trinisha that's going to be closing us out. There she is, our
Yes,
fearless leader.
hi. I had
Hi.
to pull over, so I'm still in my car. It was such a rich discussion that I had to pull over and take notes and was like, whoa, wow. So that's why you see my background in a car. I really, really enjoyed this conversation. I really learned some things as well. And some important things that was pointed out again, from Yvette. Thank you. Just talking about racism and how it starts at systemic level from the health, from the hospitals down to the community and in between. And then just to hear too, I didn't even know that the Black nurses was not allowed to be a part of the nursing association. So that is important. Who's teaching the current students? What was their way of doing things? Is it still relevant today? And just how times has changed. And also with the food deserts, like I know we had the food equity work group today, and Sherman was a part of that team where they went out to, identify like the food deserts, what was they selling in the different corner stores. And, in those high impact zones, like you see a lot of corner stores and they do sell like the Roman noodles and, microwavable meals. So what we do in health and wellness and within the health department is a lot of education and health promotion. And Trina leads a really good program with her evidence-based programs, from the DPP programs to the Dine and Learn program. And you see Sherma all throughout the communities, with her vegetables and her fruits, talking about healthy eating. Prevention Link be out in the community promoting the DPP DSMES program. Now we're about to launch our childhood obesity program. We're planning on bringing back the remote patient monitoring under Prevention Link 1. We work closely with community pharmacists to help those patients who couldn't get access to the pharmacy to get their medicines, to work with the community pharmacists so that their medicines could be mailed to them. Prevention Link is doing a lot in the community, and not just Prevention Link, again, the chronic disease program. And we're going to continue to do the work around health equity. There's so much to be done, and we look forward to continue to partner with the group that we do and looking for new partnerships. And now all of you are partners. Some are our partners, and we look forward to continue this important work. And this was a really, really good discussion. I can't wait to share the video with CDC. So thank you all.
Thanks, Ms. Tornisha. And thank you very much for joining us, to our panelists, for your time today. Look forward to working with you again. So thank you. And I think
Thank
that's
you.
it. I know we're after 6, so I think there'll be an evaluation, you guys, those who've still stayed on with us. So please take your time to fill that out. And thank you for joining us today. Have a
Nice to meet
blessed,
you, ladies.
safe day with all this weather,
You
you
too.
guys.
Yeah.
Thank you.
Thank you.
Bye-bye.
Thank you.
Bye.
Thank you.
Bye.
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 Bye.